Good afternoon, everyone. Welcome to this online community chat hosted by the University of Waterloo. My name is Sandra Banks, and I serve here as Vice President, University Relations. We're calling this series Ask Our Experts, and we're very happy to share that this is the second in a series of 6 noon hour online chats happening every Wednesday through the noon hour, running through right until June 10th. And we all know that much has changed in how we communicate with each other over the last several weeks. We also know it's important to stay connected and engaged with our colleagues, with our neighbors, and with our friends over this period of time. And we know from experience that hosting talks and community lectures and events at our public libraries and community centers have been very well received. And so we're pleased to continue this kind of engagement online, of course, where we can connect the community with the experts and the knowledge that are such a strong foundation that runs right across Waterloo, whether it's the university or right across our community. And it's also important at this point to acknowledge that we live and work on the traditional territory of the neutral Anishinaabe and Haudenosaunee peoples. The University of Waterloo is situated on the Haldimand Tract, land promised to the Six Nations that includes 10 kilometers on each side of the Grand River. Let me share a few tips just as we get underway with how you can manage the layout of the screen that you're looking at and how to ask questions from our speaker and from our moderator. To change the layout of the video chat, hover over the gray button that's at the top right-hand corner of the video screen, and you can toggle over it and change how the screen is formatted. If you have any questions for our speaker, please use the Q&A on the right hand side of the panel. You'll find it there. And you can direct questions to the drop-down bar for all panelists. If you are having technical difficulties, you can go to the chat section and send a message directly to the host. This event will be recorded as well. And so if you want to recommend it to someone or watch it again, you can look for it on the official UWaterloo YouTube channel, channel after the event. So I think it's time that we can get this underway. It's now my pleasure to introduce our moderator for this afternoon's chat, Lily Liu, who is our Dean of the Faculty of Applied Health Sciences at the University of Waterloo. Over to you, Lily.
Thank you so much, Sandra. I would like to welcome everyone to today's webinar. This is the second of the University of Waterloo's COVID-19 Ask Our Experts series. Over a period of 6 weeks, we bring an expert online through this video link to speak on a topic of interest to our community that is affected by the current pandemic. In the wake of COVID-19, many in our community are overwhelmed with the questions and uncertainty about the pandemic and its effect on our well-being, our health, and also our economy. The University of Waterloo experts are here to share their knowledge and to answer questions from our community. Today's topic is on long-term care and our loved ones, and our expert is Dr. John Hurdies. John Hurdies is a professor in the School of Public Health and Health Systems. His primary areas of interest include geriatric assessment, mental health, healthcare, and service delivery, health information management, social determinants of health, and quantitative methods. He is the Senior Canadian Fellow of InterRI, a 35-country network of clinicians, researchers, and policy experts focused on improving quality of care and quality of life of vulnerable persons of all ages. He also chairs InterRI's International Network of Excellence in Mental Health and the InterRI Network of Canada. With more than a third of long-term care homes in Ontario experiencing a COVID-19 outbreak, it may seem like there's nothing that can be done to help our parents and grandparents deal with the pandemic. Professor John Hurdies and his team of international researchers have developed a new screening tool that anyone can use to help elderly loved ones stay safe. Professor Hurdes joins us today to share his work and answer your questions about COVID-19 and the elderly. Professor Hurdes, welcome. To begin, I could just start by saying that we know there are, to date, over 70,000 confirmed cases of COVID-19 in Canada and over 5,000 deaths. Professor Hurdes, why is this virus disproportionately targeting this vulnerable population?
Good afternoon, Lily. Thank you for having me join today's session. It's a pleasure to be here with the Waterloo community. The COVID pandemic has been a real challenge for people of all ages. It has affected people of different ages, right from children all the way to older adults, but it has disproportionately affected older adults. And the reason for that is really two major things that are associated with the aging process. The first is the concept of frailty. So what we mean by frailty is that people accumulate a series of deficits over their life course that make it more difficult for them to deal with external challenges to their health and well-being. So frailty makes you more vulnerable to an attack on your system like COVID-19. The other technical term that you hear in the aging literature is multimorbidity. And what that means is that you have illness in a variety of different parts of your body that make you more vulnerable to illness as well. And one of the things that's emerging about COVID is it's not just a respiratory illness. It seems to affect the blood system, the heart. There's cognitive effects potentially related to stroke. So COVID seems to be a thing that attacks the whole body. And if you have illness spread through your various major organ systems, that makes you more vulnerable to COVID as well. One of the things that might be a bit of a source of confusion for Canadians in listening to the statistics of COVID-19 is the reference to deaths in the general community and deaths in long-term care, where we know that 80% of the deaths today in COVID have happened in long-term care. What is meant by that when it's reported is really two different major care settings. In Ontario, we have something called retirement homes, which are unregulated facilities that provide housing and a limited amount of care to older adults. And then we have long-term care homes, which more conventionally you'll hear referred to as nursing homes, which are regulated and are staffed to provide clinical services. When we hear that 80% of deaths have happened in long-term care, they're actually combining retirement homes and nursing homes together. The one bit of information that's missing that I would also view as part of the continuum of care is home care. So there's lots of people who receive services in the community, and because they have a family member who's able to provide them with support, they're able to stay in the home. Many of those people look just like the residents we see in long-term care homes. So I think we should really be thinking about each of these three settings if we're thinking about the frail, vulnerable elderly in the long-term care system. And the reality about those care settings is that each of them deals with a very large population of people at very high risk levels. So the World Health Organization has said that the people at the top of the risk categories for COVID-19 related mortality are people age 80 and over, and people who have one or more underlying health conditions. Well, that's actually 60% of the nursing home population and 40% of the home care population. So these care settings deal with the most at-risk population that we'll see really anywhere in the country.
Thank you. That's very helpful. We've got some questions that were sent in ahead of time, and perhaps one of them that I like to share with the audience is related to what you just said. Is the question: why does it seem that long-term care workers, so the staff that are working in these settings, have higher rate of SARS-CoV-2, which is the name of the virus for COVID-19? Why is it that this population have higher infection rate than the general population?
So if we think about the general population, that's people like you and me that may be working from home, people that are in the general community, not working in the healthcare system. we have chances of being exposed to the coronavirus in a variety of ways. If we touch surfaces when we go out into the community, if we're shopping perhaps, or if we're near somebody who sneezes and we may be exposed to the droplets, that can happen to all Canadians. And so we do see people in the general community get infected. But people in long-term care are healthcare workers. They are on the front lines dealing with people who have a variety of illnesses, so they're more exposed to people who've gotten the coronavirus infection, the COVID-19 infection. And so their risk levels are higher because they're exposed to more people who have this illness. One of the mistakes that was made, in my view, with respect to long-term care and home care is there was a sense that long-term care and home care were not like hospitals, and so staff didn't need personal protective equipment or PPE. We needed those in the hospital settings. That was a mistake for a variety of reasons. One, we now know that COVID has come into a lot of long-term care homes, and so staff can be exposed if they don't have the proper protective equipment. But the other mistake is that we know that there's an asymptomatic phase to COVID where people could feel fine, but they're in fact carrying the infection and spreading it to others. And so by staff not wearing PPE, in long-term care homes, they could have inadvertently brought it into the homes when they were in the asymptomatic phase. So that failure to get personal protective equipment to home care staff and long-term care home staff, I think was one of the things that went wrong in the early stages of the pandemic.
What about, can you comment, Dr. Hurdies, on the fact that the types of service providers in these facilities are perhaps making lower wages and need to work in multiple settings? Is that a factor as well?
Yeah, it's a very big factor. There's several things that have affected the ability of long-term care homes to deal with the COVID-19 challenge. So first of all, the predominant representation of staff there are personal support workers. So in a previous study that I was involved in with one of the listeners who's online today, we did a study of staff time measurement in long-term care homes. And what we found is that in long-term care homes, 75% of the care comes from personal support workers who are very dedicated people, but they have a limited amount of training on the clinical side. By comparison, in a complex continuing care hospital, about 3/4 of the care comes from registered nurses. So it's a complete inversion of the training levels for the nursing staff and the care staff that are in those organizations. So we have a couple problems. One is that their wage rates are not very good, and so they have difficulty with achieving a living wage. Second is they're often offered part-time positions, so they have to work in multiple homes. So as soon as you work in multiple homes, if one home has COVID and you get exposed to it, the chance of you bringing it into the second home go up. So there are human issues in terms of the things affecting the staff who provide the majority of care that come into play. The second issue, though, is the limited clinical capacity that long-term care homes have. So we often think about long-term care homes as not part of the healthcare system. They're a place where people would go to live in the last stages of their life, but they're not like a hospital, we would think. And in fact, the Canada Health Act does not include home care or long-term care under the Canada Health Act. The challenge is that when you have a major infection enter a home, like the COVID-19 illness, the staff that are there don't have the capacity to deal with a major acute challenge like that. When 3/4 of the care comes from staff members who aren't really particularly trained in clinical practice, and there's a very limited number of nurses, access to physicians and other health professionals is limited, it means the capacity of the home to deal with a major challenge like COVID becomes limited because of the resources that they just don't have.
Yeah, that's very interesting. So given that this particular pandemic is making the weaknesses of the the continuing care center in all its manifestations, as you originally described, is bringing those weaknesses up to the surface and making this older adult population living in those facilities or congregate living more susceptible. Do you have any hope that coming out of the pandemic, we will see a change in the way we provide services and living arrangements for this population?
Well, I think we have to. You know, it's hard to predict the future, of course. I mean, who among us thought in November that all of us would be working from our homes for 8 weeks and not having an uncertain future, that nobody would be able to fly around the world the way we used to. So, you know, it's Yogi Berra's statement of it's difficult to make predictions, particularly with respect to the future, is very true. I think the size of the catastrophe that we've seen in long-term care is large enough that it's going to stay in everybody's memory for a long time, including our political leaders. When I look at the leaders of various political parties at federal and provincial levels, I think I see a sincere sense that this is a problem that has to be addressed. In some cases, it's touched people very close to home. So I think it is seared in the memory of Canadians what has happened here. I think our challenge is, can we act in a timely enough fashion? And so I mentioned earlier the Canada Health Act does not include long-term care and home care. The Roanoke Commission around 2002 did recommend introducing home care into the Canada Health Act, but it kind of stopped before it started because of federal provincial conflicts about whose territory healthcare is and home care is. And so nothing really happened with the Roanoke Commission for several years until finally there was a health accord put in place where money went into home care. There was a more recent agreement again where additional money was put into home care, and it was conditioned on some parameters for performance measurement that provinces had to show. In the best of worlds, I would like to see long-term care and home care come under the rubric of something like a Canada Health Act where we could have national standards. My concern is that the federal provincial wrangling may stop us from making any progress. And so I'd like to see tangible action where the provinces and territories work with the federal government now to try to address this and try to come up with some quick solutions that can be implemented, because it's not like the health needs of this population is going to go away. And if we have something like a second wave coming to us, there's urgency to get this right sooner rather than later.
Yeah, absolutely. I agree with you. So what you're saying actually is related to a question that came in before today's webinar, and I'll just read it to you. Long-term care is currently provincial responsibility, and I think we might be able to take the liberty of expanding long-term care to include home care and also other kinds of care facilities. So the question is, will the federal government set a national inquiry to determine and create new guidelines in light of the tremendous failure the long-term care system across the country during the COVID-19 pandemic? Would you agree with the need for something like this?
Well, I think we need to have a very careful, rigorous look into what happened. The scientific community will contribute to that. Politicians will contribute to that. Advocacy groups will all contribute to that discussion, and I think it's worth having that conversation. But I think there are some tangible things we can act on sooner rather than later, based on what we've learned. And we don't have time for an inquiry between May of 2020 and September of 2020, if that's when a second wave with the influenza season hits us. So I'm not sure that inquiry is necessarily the answer, but rigorous review by multiple stakeholders will certainly happen. In my own research, I'll be examining what happened very carefully, because I'm able to do research that spans most of long-term care across the country and internationally. And so we're very interested to try to identify who is more at risk and what can we do to manage that more effectively. I suspect what will likely happen between the provinces and territories and federal government will be some kind of introduction of additional monies by the federal government, because the pressure is on them to do that. and then some terms set around that, around how that money will be used and what performance we expect to see in long-term care. That was the model that was used recently in home care and mental health services, and I think it was something that seemed to work relatively well to do something in short order.
Related to risk, then, would you be able to, Dr. Hurdy's, speak a little bit about the risk scale that you developed, you and your team?
Yeah, so I think you're talking about the COVID vulnerability screener that we created.
That's correct.
In most Canadian provinces and territories, they've already implemented comprehensive assessment systems that my research group internationally developed for nursing homes and home care. But there's lots of blank spots. And so, for example, in those retirement homes that I mentioned, there's really no assessment that happens there at all. Then there are some folks whose home care services have been discontinued, or they may not yet have gotten home care services, but in primary care. And there's lots of vulnerable people in those pockets where we have no data as well, and no monitoring system that's being used clinically. So what we did is we created a short screening tool that could be administered by laypersons. So our idea was not to take frontline staff away. So it could be students, it could be clerical staff, it could be volunteers. It does not need to be a nurse or a physician to do it. They can do a telephone-based interview, or an interview via webcam like we're doing now. And we ask a series of questions that include COVID symptom sets, measures of frailty, measures of multimorbidity that I mentioned earlier on, as well as other psychosocial and economic vulnerabilities like signs of caregiver distress, difficulty getting medication or groceries delivered, poverty or economic loss. And we can put that all together to create a picture of people that are at very high risk in the community or in these settings where no assessment is happening. So we can target services to those folks in a more expeditious manner. Because one of the concerns that I have is that we have a pretty good understanding of the impact of COVID in long-term care homes and in retirement homes, because these are easily identified organizations where we know there's people there. But if we think of people in home care, people live on their own in the community in home care, and there's not a collective building that they come to that we would say, okay, there's a lot of people that seem to have died out there. And then there's lots of vulnerable, frail people in the community that we don't see at all. And those people may be deaths that are undetected. And if we could intervene earlier to help them, there might be some benefit. And so that's the idea behind our screener.
That's great. Now, based on the fact that you do a lot of international work, and the tools you have developed is quite widely used around the world. Are you aware, first of all, is the plan that this particular scale would be used in other countries? And are you aware of other countries that are in other countries that are doing actually better, have better outcomes, and what are they doing that's different? This is actually related to a question that's just come up online.
Okay. Yeah, there's huge diversity in what's happened internationally, from countries that have done well to countries that have had a huge disasters. So if we think of some of the countries that have had challenges, Italy comes first and foremost to mind, and Spain, because they were, I think, the countries that really got everybody's attention in the Western world, in Europe and in North America, when we saw the huge challenges that are there. A big difference between the Italian system and the Canadian system is that the Italian system has virtually no home care and long-term care. So only about 2% of Italians get home care, only about 2% are in nursing homes, compared to more like around 10% for Canadians. So for Italy, the main place for care for elderly people is in hospital settings or at home in primary care. And so when those people got sick, they went to hospitals and quickly overwhelmed the system. The Spanish system is not all that different. We know a little bit less about Spain in our international group because they haven't done as much to implement our systems as the Italians have. And so part of it may be because of the way the healthcare system is organized. But then other European countries seem to have done better. There's something interesting happening in the Nordic countries. Canadians often feel this inferiority complex compared to Scandinavians. You know, we think we're nice people, but not as nice as the Scandinavians. Well, there's a huge difference between those countries if we look at Norway, Sweden, and Finland as examples who've taken very different approaches. The Swedes and the Finns have, the Norwegians and the Finns have emulated the Canadian approach of social distancing, people staying at home, whereas the Swedes have not. Well, the death rate in the Swedes seems to be about 10 times higher than the Norwegians and the Finns. So, you know, we'll hear about the Swedish model of sort of not doing the kind of social distancing that we've had, or at least the sheltering at home. I have real doubts that that's going to pay off as the right way to go. I think what Canada has done is the right example. So then we've got South Korea, which was interesting. In South Korea, they were very aggressive very early on in terms of testing and containment and tracing. I think much more than most other countries have done. And so they had this very low rates of COVID outbreaks and low rates of exposure in their long-term care homes. But now we can learn from the South Koreans of what happens when you ease restrictions and you know, how big will a second wave be. The country I'm sort of probably most intrigued by as a Canadian, because I see lots of similarities, is New Zealand. Now, in research that I've sent out for publication, I've created some models for mortality in long-term care that pretty much match what we saw in Canada. And when I apply that model to New Zealand's data, what I expected to see in New Zealand was around 150 deaths in long-term care homes. They had 10. So much lower mortality rates. New Zealand is about to declare that COVID is eradicated. Now, the thing about New Zealand is it's not an easy country to get to. It takes you 20 hours to fly there. It's an island, so they were able to control access to the borders. They moved very aggressively, very rapidly to contain the pandemic. They very quickly quarantined people when they came in. And it seems like they've been able to keep the illness out of their country. And so, you know, it'll be interesting to learn what their experiences were. The other thing that we'll be looking to international data for is what happened to people that were and were not exposed to COVID. So there's two threats to the well-being of nursing home residents and home care clients. The first, most severe acute threat is the COVID infection itself, because of all the bad things that it can do to frail older people. The second threat is all the secondary consequences of social isolation. So, you know, the challenges of having to lock down homes and of not being able to visit elderly relatives in the community to contain the virus may lead to secondary health problems. So we know that people are not coming in to deal with existing chronic illnesses like heart failure or COPD. And so they may be experiencing decline in their health because of a lack of chronic disease management, but also the inactivity that they're experiencing can also make them vulnerable. So they're less physically active and exercising. So their ability to perform day-to-day functions like getting dressed or doing housework may be impaired. And then depression and isolation is a major threat to their well-being as well. This is not easy for anybody to do, let alone a frail elderly person that may be living on their own in home care, or somebody with dementia living in a long-term care home that can't comprehend all the things that are happening around them. So we have to be careful about both the COVID threats and the secondary consequences. And even in a country like New Zealand that have not had COVID, we can see what their experience is because they did have the lockdown. So those secondary consequences may well show up there as well, and we can learn from them.
Yeah, you make some really excellent points there. I'm hearing, for example, that older adults are because of the social isolation and separation from their immediate family members and volunteers who will make up such a huge sector of service provision, that we're seeing older adults experiencing delirium. as another secondary, which can be prevented, which then brings up the question whether or not volunteers and family members really should be deemed as essential service providers during this. And hopefully there's going to be lessons learned for the next time anything like this happens. But you brought up the concept of frailty, and it is related to a question that's just come in online here. And I wonder if you would be able to address it. It's so the question is, if you can describe what the main difference is between the COVID screener that you developed and the frailty index. Is it more specific to the symptoms of COVID? And because this is it's a pandemic internationally on a global scale, I think your screener could be very, very, very important. So that's the question: is what is the difference between the frailty index and what you've developed recently?
Yeah, so our screening tool has four main parts to it. So it has a measure of COVID symptoms that are based on the symptoms that World Health Organization, CDC, Public Health Agency of Canada, and other organizations have identified as major symptoms. So we can track that, and for the people that are symptomatic, we can get a sense of how severe their illness might be. It does not help us with people who are asymptomatic. That will only come from testing, but at least we can pick that piece up. The frailty measure that we have is based on something called the assessment urgency algorithm, which considers four areas of physical disability, of things like difficulty with dressing yourself or performing personal hygiene, one measure of cognitive impairment, a measure of caregiver distress, a measure of self-rated health, of depressed mood, of shortness of breath. We put that together into an algorithm that we've shown very strongly predicts who needs geriatric assessment, who has prolonged stays in hospital. And it's sort of a composite measure of things that relate to frailty. The frailty index that the person referred to is typically based on a count of about 30 different areas of potential indicators of frailty that get added up and you calculate a proportion. The challenge with using the frailty index over the phone is that the person will be worn out. By the time you've asked about the 30th different symptom, in addition to other things, that they'll be too tired, and we can get to the point much faster. We also include with this a measure of multi-morbidity of different diseases, and the social vulnerability, like are you running short of money? Do you have difficulty getting groceries? To put a full picture together about the person's risk. So any of us can go online today to the Ministry of Health website and complete the set of questions around COVID symptoms. And our screener parallels that and gives similar advice to it. But that's ministry tool doesn't ask about frailty. So I'll give you an example of somebody that I would be very worried about. Two different people have two different scenarios. So one person might have very severe shortness of breath as a symptom. If they did the typical self-assessment, they would be advised to get urgent care because they may be having a heart attack, other things could be going on. So they'll be seen by the healthcare system. But somebody who has a limited number of COVID symptoms that are not currently life-threatening may be told, well, you need to self-quarantine at home for 14 days and then just check in to see how you're doing. Well, if somebody lives alone, has no family member in contact with them, and they have the early symptoms of COVID and they're told to self-quarantine, they may deteriorate without anybody having eyes and ears on them. And so our frailty index would identify who is going to be more challenged in dealing with those symptoms. And our isolation measures would say, well, who are the people that are on their own? So somebody with moderate symptoms who's frail and is alone is somebody I'd be very worried about. And our screener will put those people into contact with the primary care system for follow-up.
Right. Yeah. Such helpful, very practical information. I have time. We have time for just one more question. And if you don't mind, I think there's a question that's come before the session today and another one that's online that are sort of related. So they have to deal with this, lots of family caregivers are trying to balance the risks or the benefits of leaving a parent with dementia in a retirement home versus bringing them home to their family. And then also then related to that question is how would they manage the isolation in one's home, the social isolation, when we're talking about older adults that are living with dementia.
Yeah, this is a really tough spot for these folks to be in. And the question refers to retirement homes. So I'm going to make a distinction that I made earlier between a long-term care home and a retirement home. So a long-term care home is provincially regulated. They have nursing staff, personal support workers, and some physician contact from outside that would provide services. And they tend to deal with the most functionally impaired populations among the frail elderly that are not in the hospital because of acute problems. Retirement homes are unregulated organizations that focus more on housing. They may have limited clinical services, but often the home care agency provides clinical services to people in retirement homes. And they tend to have somewhat lighter care needs. So of the two scenarios, it's probably more feasible for a family member to take a relative out of a retirement home to their home than out of a long-term care home, simply because the person will likely have less severe impairments. But we need to think about the capacity of the caregiver to deal with this issue as well. So in other research that I've done, I've shown that in home care clients, 35% of home care clients have caregivers who were distressed last year before COVID hit. Now the rates of caregiver distress will be much higher. And so the challenge is you may, administratively be able to remove somebody from a home, but do you actually have the capacity yourself to provide that care? If you can, then it may be a reasonable option for a limited amount of time right now, but it may be for many of these folks that they just don't have that capacity. The main reason that people end up in nursing homes instead of long-term care homes, instead of home care, is often that the family couldn't cope with the person's care needs, and that was before COVID. And so there's an appeal to this to say I'm going to get my loved one and take care of him or her, but the challenges will be substantial, and there's very few community resources being offered right now to support folks in the community.
Yes, such helpful information, and you have such a wealth of expertise. I think we'll have to do a few more of these sessions, but I'm hoping that the participants today will understand that we're not able to address all of the excellent questions that have come in, and clearly this is a critical issue for many of us in the community. I'd like to thank Dr. John Hurdies for speaking with us and for sharing his expertise on this very critical topic. John Hurdies is professor in the School of Public Health and Health Systems at the University of Waterloo. Thank you.
Thank you, Lily.
If you would like to learn more about this topic, you can find some additional resources on the screen now and also in the chat feature. Also, if you would like to view this talk again, the recording is going to be uploaded to YouTube shortly. Join us next Wednesday at noon Eastern Standard Time for a dialogue with our third expert speaker, Shanna McDonald, Professor, Department of Communication Arts, on the topic, social media and our quarantine life. This is a topic I'm sure we can all relate to. To register and learn more, please go to www.uwaterloo.ca/community. Thank you again to all of you for joining us, and have a wonderful day. Goodbye.